Hi, Mike Gibson, Susheel Kodali, talking about the TRISCEND 2 trial, looking at a tricuspid valve replacement strategy. Talk to us about what you found.
Oh, great. So TRISCEND 2 is the pivotal trial to sort of look at whether transcatheter tricuspid valve replacement can actually improve outcomes in patients with severe TR. I think we've seen that TR, although we've historically underappreciated it, is being increasingly recognized as leading to sort of debilitating symptoms and poor outcomes. And surgery sort of remains limited. So there's sort of an unmet need for transcatheter solutions. And obviously, last year we had data from triluminate and edge-to-edge repair, which was interesting. And this is sort of a different modality rather than repair replacement. I think, and I think the study is a total of 400 randomized patients. What's being presented today is the first 150. The trial had an FDA breakthrough designation, so it's sort of a unique trial. The first 150, we get a look at limited outcomes, the initial 30-day safety as well as some 6-month effectiveness endpoints. The entire cohort is enrolled, but we don't have those outcomes yet. Follow-up is ongoing, and those will be presented at a later time.
And what kinds of data can you share with us?
So in terms of 30-day safety, we looked at a serious major adverse event rates and compared it to sort of expected rates based on a surgical series. And what we saw is this in this highly comorbid population, mean age was in the around late 70s. STS score for mitral valve replacement was around 10. And this was a very symptomatic population with the majority of patients NYHA class 3 or 4. 20% of patients had ascites. The safety profile was less than the expected MAE rate. The MAE rate was 27.4%, and it was primarily driven by bleeding events and needs for a pacemaker. And this was less than the expected MAE rate of 43.8%.
Can I ask how bad, just to back up a little to the baseline characteristics, how bad was the TR? One of my favorite words out there is torrential TR. So
Right.
how bad was the TR at baseline?
No, that's a great point. I think a third of the patients had torrential, and more than 50% had massive or torrential. So this was a patient population that had a lot of TR. And the majority of it was secondary. Nearly 3/4 was secondary, and some was mixed, but about 15% was primary. And what's different from some of the edge-to-edge trials is more than a third of the patients had a pre-existing pacemaker, because that's one of the limitations in edge-to-edge, because the pacemaker can interfere with the repair. But more than a third here had a pre-existing pacemaker.
Interesting. So sorry to go ahead with some of the safety outcomes. You're on a roll.
Yeah, no. So, bleeding rates in this population are high. It was about a 10% severe bleeding rate. They were not all vascular, some were GI and other factors as well. And that's we don't know. I don't have the breakdown from this trial yet, but that's based on earlier experience. The pacemaker rate, if you look at patients without pre-existing pacemakers, it was around 22%. If you look at the entire population, it was 14%, 14.7%. That was the major, but there were 3 cardiovascular mortalities at 30 days, and this is a rate of 3.2%.
And how does that compare with the surgical comparator?
So there's a lot of different series out there. If you sort of look at one of the largest series, which is the Medicare fee-for-service claims, and this looks at data from 2011, 2018, the mortality was 7.6% at 30 days.
So it looks favorable compared to that historical.
Correct.
Great. Well, when can we expect to see the data from the entire cohort?
We're follow-up is ongoing. I suspect sort of towards the end of next year. I don't have exact timelines, but I think likely end of next year. I think what's important is this effectively eliminates TR. And when we look at sort of edge-to-edge versus replacement, there are pros and cons with both. But one of the pros with replacement is 98.8% had less than moderate and 94% had less than mild. And so I think that's a very big difference. And whether this translates to improved clinical outcomes is what's important. What we've seen, at least here in the early 6-month look, when you look at sort of, we did a win ratio using KCCQ, NYHA, and 6-minute walk distance, and compared it to medical therapy. The treatment with TTVR resulted in improved functional outcomes, and the win ratio was around 4.6. And
Wow.
obviously, this is initial 150. We'll wait for ongoing. But when you look at these quality of life metrics like KCCQ, NYHA, and functional status like 6-minute walk, these are hard metrics, but this is what really matters. And this is one of the challenges in this population is we're looking at functional outcomes and not just mortality.
And that's a win ratio comparing the patient to themselves.
Patient to optimal medical therapy. So this was a 2-to-1
Okay.
randomization.
Okay.
Yeah.
Great. Well, congratulations on the progress. Look forward to seeing the final results. And thanks for joining us today.
All right. Thank you so much for having me. Take care.
Thanks. Thanks, Susheel.
Bye.